The next 15 minutes will be looking at how to approach a patient coming to you with headache. So we have two patients here. One is a 30-year-old lady without any other comorbidities who presents with headache since the last 2 years. And her CT scan was normal. She has done 2-3 CT scans, it's all normal. But now, since last few weeks, she has been having headache more often and even disturbing her sleep. The second is again a similar 30-year-old lady, again with no comorbidities and having headache since last 3 months. Again, she has done 2 CT scans, which was normal. And in the last, similar to the first lady, last few weeks, her headache has increased. And even on getting up, she's been having headache since the last 2 weeks. So what is the difference between these two patients who comes with headache? So this is both the patients ultimately had an MRI. First patient's MRI was normal. The second patient, you can see there is a mass lesion in the cerebellum. Okay, so basically this first patient, what she had was what you call as a primary headache. And the second patient had a secondary headache even before, but it was not picked up because she has done only CT scan and maybe somebody didn't examine her closely to look for any papilledema, etc. So primary headache or headache by itself, and it's not associated with any other underlying disease. Okay, and this is not a symptom of any underlying disease. That is when you call it somebody having a primary headache. And secondary headache are headaches that are due to underlying medical condition, and some of these conditions can be serious. So also we should know that 18% of all patients with a headache can be having a secondary headache. So we should be very careful before we diagnose somebody to have a primary headache, because 20% of the time you can miss a serious issue. And rarely a patient with a secondary headache rarely a secondary headache can occur in a patient with primary headache. So this is well known, like you may be seeing a patient for many years with say migraine or something, and patient can develop something else which if you are not careful you can miss. And also secondary headaches can trigger a primary headache. This is very common following a trauma. So patient no headache till now, had a subtle trauma, then having headache, which can in fact be a migraine headache which has been triggered by that particular incident. So what are the clues towards a secondary headache? So this we can use the mnemonic called SNOOP. So before you do anything, make sure you get a very detailed history, get a detailed drug history, very, very important, and make sure you do a fundus examination and look for neck stiffness and of course blood pressure. Very often we have seen patients coming with headache who having high BP which has got missed out. So what is this SNOOP? So SNOOP, S stands for any systemic symptoms the patient can be having and including fever. N stands for any history of any malignancy in the past which can be a secondary which is causing the headache. Any deficits, neurological deficit has to be ruled out before you can label anybody having primary headache. O stands for sudden onset of headache. So anybody coming with a sudden onset of headache called thunderclap headache, it is not a primary headache. And other O stands for elderly. Anybody having headache first time after 50 years of age, you have to be very careful. Pattern change, this is another thing which we often miss out. A patient you have been seeing for a long time, suddenly saying that I am getting headache. You should ask is there any change in the pattern of the headache. Positional headache, this is also very important. Just ask the history whether headache is more when you stand or any particular position is increasing or decreasing the headache. Headache precipitated by cough, again should make you suspect a raised ICP or a CV junction anomaly. Papilledema should not be missed out. And progressive headache. So this is something which you should not be ignoring. Somebody is saying that I've been having headache since last 6 months, but now it is increasing. So that also is a red flag. And lastly, headache occurring during pregnancy or puerperium is also should be fully investigated. Now, if you look at all the primary headaches, you can classify into three big groups. One is migraine, second thing is tension type headache, and third is what you call as the TAC headaches or trigeminal autonomic cephalalgias. In this TAC headache group, there are the groups like cluster headache, paroxysmal hemicrania, sun CT, SUNA, and hemicrania continua. So this is how you broadly classify your primary headaches. Now there are rarer primary headaches. Some of them can be brought out by some specific action like primary cough headache, primary sex headache. So, but these are the headaches you should be very careful before you label them because they need thorough evaluation before you can label them as a task-specific primary headache. So we will be looking at these headaches one by one. Migraine. So there is a strict criteria when you can diagnose somebody to be having migraine. So he or she should have had at least 5 attacks with the following features. That is, the headache should have lasted at least for 4 hours, treated or untreated, and they should have at least 2 of the criteria, that is unilateral, pulsatile quality, moderate to severe pain on a 0 to 10 pain scale, and the headache is, it should be causing some inconvenience to the patient. And also it should be having at least one of the following, that is nausea, vomiting, or phonophobia and photophobia. So this is the strict criteria before you can call somebody as migraine. So somebody coming to you first time or even second time, there's no chance you can label him as a migrainer. So all these diagnostic criteria you can look up from the International Headache Society guidelines, which is freely available online. And you can also, so a patient with migraine can be having a migraine with aura or without aura. Another important thing is whether the patient is having episodic or chronic. So anybody having headache more than 15 days in a month, which is somebody who is having a chronic migraine. So less than 15 is episodic. So if you look at migraine, they can go through these stages of migraine. So first you have something called prodrome. So during this prodrome, the patient will be having tiredness, they can be yawning, they can be fluid retention or craving of food. So this can occur for few days, even few days before the actual headache occurs. Then they can go on to the phase of aura, which can be either sensory aura or motor or even visual aura, which is the most common. And sometimes this can be a mimicker for a stroke. Suppose first time somebody is coming with a motor aura. Then you get to the stage of headache, and the headache will increase in severity, and usually during the headache they can have phonophobia, photophobia, and what you call as osmophobia, it is smell. Then they might going to the phase of resolution, where some of them go to sleep and they wake up, and there is something called postdrome, where the patient is not fully himself or herself. They feel tired and they'll take some time to recover, and then they become normal. So one important thing is, even when they are normal, patients with migraine can have some small symptoms like light intolerance, noise intolerance, they feel bloated up, etc. So these are the phases of a typical migraine. But you won't get all patients going through these phases. Some of them can skip, some of them may not have aura, some of them may not have prodrome, etc. But it's very important from a treatment point of view if you can identify these 5 phases of migraine. Coming to the tension headache, so when do you consider somebody to have tension type of headache? So a very useful clue is these are the headaches which is totally symptomless. I mean, like they don't have any features. So they'll just say that I've been having headache. If you ask about photophobia, nothing will be there. And and it will be it will be feeling like a tight band across your forehead. And another 2 clues for this is, one is they can have diurnal variation. That is, as the day progresses, the headache will increase, especially towards the evening. And the second clue is, if you palpate their scalp and the back, they can have tender spots, which can be easily palpated with using your index and middle finger. An important trigger for this sort of tension type headache. So tension type headache is basically the muscles are stiff and that is causing the headache. One of the most important trigger is bad posture at work especially, and now especially use of cell phones. So what you should know is an adult head weighs around 5 kilos and this is directly acting on your spine. As you tilt your head, this weight is multiplying. With a 15-degree head tilt, the 5 kilo is becoming 12 kilo, and if you tilt 25 degrees, which is classically when you're texting, it is becoming 5 times the weight on your spine. So this is something which is very common nowadays, which is causing the trigger for tension type headache. Next we have this trigeminal autonomic cephalalgias, and as I told you, there are some subgroups. The first is the cluster headache. So cluster headache, these are very severe episodes of headache, often precipitated by alcohol, and these are strictly unilateral headache, mainly more seen in males. This is around the orbits and temporal part of the head, and this can occur in very frequently in a single day, and this follows a circadian rhythm in a 24-hour cycle. Every day they'll get the headache at the same time, and they'll be associated congestion and lacrimation, and the patient will be very restless and agitated, unlike in a patient with migraine who wants to be left in a quiet room with the lights off. These patients will be very agitated and walking around trying to take a cold shower, etc. Why is it called cluster? Because it occurs in clusters. So they will have headache every day for the next 2-3 weeks, then they'll be totally headache free for the next maybe years or months. Then again they'll start getting this sort of headache. So this is clustering, that is why it is called cluster headache. So like in migraine, there are triggers for cluster headache, and there are other trigeminal autonomic cephalalgias which is called little cousins of cluster headache. This is similar to cluster headache, but they differ in duration and frequency. So we'll look at these very quickly. One is called paroxysmal hemicrania or hemicrania continua. So these are headaches lasting only around half an hour, mainly on one side, and some of them respond very dramatically to indomethacin. So that sometimes it is also caused indomethacin responsive headache. Next you have this very short lasting unilateral neuralgiform headache where you can have conjunctival congestion and tearing. There are 2 types of headache like this, and these are also clustered around the eye, and they can have multiple episodes of headache, very sharp headache lasting up to 500 to 600 times in a day, each lasting very short duration. Okay, so this is called SUNA and SUNCT. So why is it important to differentiate these smaller varieties of trigeminal autonomic cephalalgias? Because the treatment is totally different for each of these. In cluster headache, the trigger will be usually alcohol, and the abortive treatment is you have to give either IV sumatriptan or sumatriptan nasal spray. The oral sumatriptan won't work, or you can give them oxygen inhalation. And for prophylactic, you have to give either verapamil or lithium. Whereas in hemicrania, paroxysmal hemicrania or hemicrania continua, the main treatment here is indomethacin. And in this very short lasting unilateral headaches, the abortive treatment is IV lignocaine, and for prophylactic treatment you can give them anti-seizure medications like lamotrigine, topiramate or gabapentin. So this is very important to differentiate these not so common type of headaches. So how to differentiate the primary headache? So here you can use the mnemonic called Socrates. So we'll just look through it one by one. The first thing is sight. So where is the headache? So the tension headache, as I told you, will be bilateral. It will be like a band, as if the patient himself can tell you there is a tight band around my head. Migraine, it is unilateral usually, and cluster headache and other paroxysmal hemicrania will be around the eyes. Okay, that is the sight. Onset, here you have to take a longitudinal history as well as your cross-sectional history, because sometimes the patient may be having a episodic migraine which has become continuous now, or a tension type headache which is episodic has become a chronic tension type headache. Or you might see a patient with an ongoing cluster headache. Now, the character of the pain in tension type headache, it will be a pressing or a tight feeling, whereas in migraine it will be throbbing or pulsating and can radiate. And in other trigeminal, it will be a burning, it will be like a sharp needle pricking into your eyes, and it can radiate through the eye. Association and time duration is also other clue. So in tension type headache, it will be a continuous, whether there will be a diurnal variation, there won't be any other associated features, whereas in migraine, it will come in bouts, and there will be other features like photophobia, phonophobia, nausea, vomiting. And the trigeminal headaches will be very short lasting clusters and marked autonomic features around the eye like conjunctival congestion and watering. And lastly, we can have exacerbating or relieving factors. And in tension type headache, nothing can, there's nothing to help them. Whereas in migraine, they can have various triggers which can bring about migraine, and usually they'll rest in a quiet dark room. Whereas in trigeminal autonomic, there can be a lot of cutaneous triggers which can trigger the headache, and they'll be very restless. So this is how you can differentiate the various type of headaches, primary headaches. And there are other clues. There is something called medication overuse headache, which is from the history you should be asking this. Response to indomethacin and oxygen inhalation is also an important clue for paroxysmal hemicrania. Any tender spots you can look for, and alcohol triggering is an important clue towards cluster headache. So sometimes you can have a patient with the normal imaging of the brain, and the headache is not fitting to any of these types of primary headache we just discussed. Then you have to look for features, look for clues inside the other areas outside the brain, like ENT, they can be having a otitis media, or look at bony structures for any CV junction, any ophthalmological causes like glaucoma or scleritis, or skull-based osteomyelitis. The patient can present with TM joint arthritis, and you can mistake it for a migraine if you are not careful, or dental infection. And also look for vascular causes like any dissection. Patient presenting with acute headache, don't miss out any dissection or a giant cell arteritis. Cardiac angina rarely can present to ipsilateral side of the head. And other things like idiopathic hypotension can also present with headache, and any metabolic causes, any hypoglycemia, intermittent hypoglycemia, and drugs. Don't forget drugs, especially nitrates and estrogen in your history. So headache is a diagnosis which is contributed more than 90% with a good history, and 4% by physical examination, and only 2% is imaging helping you in the diagnosis of headaches. So patient presenting to you with headache, rule out secondary causes by using SNOOP and Socrates to see which primary headache the patient is having, because treatment differs for each of this. And if you are stuck, look for other structures other than the brain and the meninges for looking at your cause for headache.